Well, good afternoon, everyone. Those of you that are still with us, this is going to be another installment of Lessons Learned, but this time we're trying to move outside of the healthcare delivery system and begin to look at some of the partnership potentials in the areas of the broader determinants of health. So, again, Joe Buford, I'm delighted to be chairing this session, and the only bad news is that Jeannie Birch, who would, I think, have been a very interesting presenter because of her work with Habitat and her role as an urban planner, has had a dental emergency. So she said if even if I came, I couldn't articulate my words clearly enough to be understood. So she won't be joining us. But we have two fabulous panelists, and each of them will have their allotted time, 15 or 20 minutes, and then we'll have Q&A. And if we end early, we end early. And we've asked that the reception, which is across the hall, start when we finish. So do not despair that you'll have to loiter around to have a refreshment when it's over. Mushtaq, as many will know, is the vice chair of BRAC, which is the world's largest non-governmental organization, and he is also been a leader in that organization for some time and was the founding dean of the James P. Grant School of Public Health and has academic relationship with the Mailman School of Public Health over at Columbia. And Jeff Sturcio is president and CEO at Raven Martin, which is a global health strategy consulting firm, and former president and CEO of the Global Health Council. And before that, he was at Merck and Company. So we've asked Jeff to triangulate with himself in terms of public-private partnerships and the relationships. And Mushtaq is going to, I think, tell us about one of the it is a miracle success story about multiple partnerships that have really been critical to the development of an entire country. So we'll start with you, Mushtaq.
Thank you, Jo. Good afternoon, everybody. Let me start by thanking the organizers for inviting me to this very important and interesting workshop on partnership. A little apology in advance. I hope you forgive me if I fall asleep because it's in my country. It's about 2 o'clock in the morning. So a little jet lagged, but I'll try my best to present what I wanted to present. As you know that Bangladesh has been in news recently, not always for bad reason, but also for good reasons as well. In health, for example, Bangladesh is one of the 6 or 7 countries which is on track to achieve both the MDG 4 and 5. So Bangladesh is doing well, and it has been featured recently in many journals and also in popular media. But much of the credit for this obviously goes to the government and also to other actors in development. And they are the non-governmental organizations, the private sector, and also the donors who have also contributed a lot in taking Bangladesh forward. So that's what I want to talk about today. So what I will be talking in brief is about what are those miracles that has happened there, and also to talk a little bit about the role of the NGOs and how the NGOs are forging partnership with the government and also with the private sector. And then give you an example of BRAC, which I represent here, and how the holistic approach of BRAC has actually been able to address many of the social determinants of health, and so on. And then at the end, I'll try to, if I have time, I will try to show a very short video on BRAC. Lancet published last year a special series on Bangladesh, and that documented the miracle that is happening there. And as the editors of the Lancet says, that the Bangladesh story is one of the great mysteries of global health. So what is that story? Just as a background, as I'm sure you all know about this, that Bangladesh is a large country with 153 million population, and it is the 8th largest country in the world, and it is the most densely populated country in the world, if we can ignore Singapore, for example. Bangladesh was liberated in 1971 through a protracted war. But immediately after the war, some unkind people started talking about Bangladesh as a basket case. But after 4 decades, the country has shown that it is not a basket case. I mean, there is a positive deviance that is happening there. The country has turned around. In this table, I'm showing some of the development indicators of Bangladesh in comparison to some of our neighbors. And as you can see, that in terms of poverty, Bangladesh has the highest poverty rate compared to India's 27% and, of course, Pakistan's 22%. But this rate, fortunately, has even gone down now. It was about 2010 data. So the poverty rate is about 24% now, which also means that a quarter of Bangladesh are still poor by head count poverty. But despite that, Bangladesh has done well in some of the indicators, as you can see in the following columns. With respect to female primary enrollment in school, Bangladesh has the highest enrollment. More than 90% of the children are going to school, and there are more girls in school than boys. With respect to life expectancy, Bangladesh has the highest life expectancy in the region. And there is a gendered dimension to this. Until the late 1980s, Bangladesh was one of the very few countries in the world where women lived a shorter life. But this now has been corrected. Women now live about a year more than men, which is a huge improvement in terms of women's life expectancy. Similarly, with respect to infant mortality, as you can see that the Bangladesh has the lowest, and also maternal mortality ratio, which is about 194. This one shows the same countries with some of the health systems indicators. And as you can see that the per capita expenditure on health is lowest in the country. The ratio of doctors per 1,000 population or nurses per 1,000 population, Bangladesh is almost one of the worst. But at the same time, we see that the immunization rate is the highest there. 82% of the Bangladesh children are immunized. With respect to ORT, or oral rehydration therapy, the use of that for diarrhea, Bangladesh has the highest ORT use rate. And that was done because of a very good partnership between BRAC and also the ICDDRB. Dr. Richard Gorent is here, who was one of the pioneers of ORT. And they discovered ORT, but BRAC took it to the homes of everybody. Bangladesh now has the highest ORT use rate in the world. But the last 2 columns, they show that everything is not as good as it should be. With respect to skilled attendance in delivery, Bangladesh is lagging behind. With respect to the percentage of facility delivery, Bangladesh is also lagging behind. This one shows the different mortality rates and also the life expectancy at birth over years since 1970. As you can see, the life expectancy has continuously been improving, but the mortality rates have been going down. The maternal mortality has seen the sharpest decline, But unfortunately, the green line, which is at the bottom, which is the neonatal mortality, we haven't seen much an improvement in that. This one shows the total fertility rate in comparison to the contraceptive prevalence rate. And as you can see that as the contraceptive prevalence rate increases, the total fertility rate has gone down. It has almost reached the replacement level. And this is quite significant for a country like Bangladesh, which is Muslim conservative. So Bangladesh has actually done that. This is an interesting graph which shows the income inequality, which is represented here by Gini coefficient, and also the concentration index for access to different health services. And as you can see that the blue bars are the Gini coefficient, and the inequality has remained more or less the same over the years. But on the other hand, the concentration index for access to different health services has improved significantly in terms of inequality. And while the Gini coefficient is about 0.45, the coefficient or concentration index for access to different health services is about 0.15, which means that the health services are being equally accessed by the poor people. Now, the question is why it has happened. There are many reasons. You don't have to read all these, but there are a few things which I wanted to point out here. One is the pro-health policies by the government, and that is also helped and pushed by the NGOs. So one of the example is the drug policy. Bangladesh was the first country to adopt a drug policy which made the essential drugs available at a very inexpensive price. Then the government and also the NGOs started or adopted a holistic approach that promoted the social determinants of health and particularly the empowerment of women. And as you know that Bangladesh is a country where microfinance or microcredit was born, and about 80% of the poor people have now access to microfinance. So there has been a huge number of studies which showed the empowerment impact or empowerment power of microfinance. And the third thing that I wanted to mention is the role of the NGOs, the involvement of NGOs that promoted the scaling up of programs. So, for example, as I said about ORT, in the 80s, BRAC workers reached all the households in Bangladesh through house-to-house visit. So scale was a major factor that was seen in Bangladesh, and also that we have been able to really forge a very effective partnership with the government. So in that the example of family planning is important. Both the NGOs and the government have been working together in promoting family planning. Also the water sanitation and so on. I will be coming to other things a little bit later. So that's what has happened, and that's why it has happened in terms of improving the general health and development condition in the country. Now about BRAC. BRAC, as you know, is an NGO, and there are 4 guiding principles of BRAC. One is that BRAC focuses on women who are most affected by poverty, as you know. We believe in organizing the poor, which is at the heart of our work. And BRAC acts as a catalyst, creating an ecosystem where the poor can seize the control of their lives. And more importantly, BRAC believes that many of the underlying causes of poverty are interlinked. poverty is not just about shortage of money or employment, but people are poor because they don't have access to healthcare. People are poor because they don't have access to education. People are poor because their women are not empowered. So in order to address poverty, one has to address all the causes of poverty. And that's why BRAC has undertaken programs on education, program on healthcare, program on legal rights and training, and also micro-enterprise development. Now, what kind of partnership we do with the government? There has been a large number of partnerships that NGOs do in Bangladesh, and so does BRAC. But that doesn't mean that all the partnerships have been successful. There are some failures there, but mostly I must say that the partnership that we have with the government have been quite successful. We know about the immunization program. We know about the maternal, newborn, and child health program, the national malaria control program. All these are done by NGOs and BRAC together. Similarly, with respect to the national eye care program, also a civil society watchdog called the Bangladesh Health Watch. So these are all done jointly with the government. And finally, I wanted to give you a specific example on the TB program. And BRAC started developing its TB program back in the mid-1980s. And the solution we found was what the WHO called in the early 90s the DOTS program. And there we used the community health workers in order to identify the patient as well as provision of treatment. Then in 1994, BRAC signed an MOU, the Memorandum of Understanding with the government, and from 1996 we started scaling up the program throughout the country. In 2003, both BRAC and government received a grant from the Global Fund. So what are the roles of the partners, the government and BRAC in this case? Government provide the oversight, and also they provide or supply drugs, but NGOs implement it nationwide, and BRAC is taking the role of implementing it in 2/3 of the country. And both government and also BRAC are the principal recipients of the Global Fund resources. As you can see here, the progress with respect to the TB program, the case notification rate has been increasing continuously, particularly with respect to all types of TB program. Similarly, with the treatment success rate, it has been increasing continuously, and it has a long time has exceeded the WHO standard of 85%. So that's about partnership. These are kind of successful partnership, but also there has been cases where we haven't been able to equally work with the government on certain things, and it depends on the governance of the government as well as the issue of the commitment of the government. So that was what I wanted to say. Present in short about Bangladesh and also BRAC and also the kind of partnership we do. And now I would invite you to see a 7-minute video on BRAC. Thank you.
Bangladesh has been a hotbed of innovation and captain consciousness. BRAC, a development organization founded by Sir Fazl Hassan Abid in February 1972, has been a pioneer and a catalyst for change in the struggle against poverty. Today, we're one of the world's largest development organizations, active in around a dozen countries, providing tools that millions use to better their lives. and work to restore rural women. Initially aimed at encouraging self-employment, our microfinance and YPCC small enterprise development takes the advantage of the multiplier effect of employment generation. For BRAC, easy ownership is both a principle and strategy. Reform studies and action groups known as Bengali have shortly summoned to strengthen the voices of the poor, creating a platform for rural civil society and government to work together to meet local development values. Women in these groups speak with pride about stopping illegal underage marriages through discussion and conflict resolution. BRAC pioneered the training of community health workers in the early 1970s. In Bangladeshi villages that BRAC operated, we began working with a Sherifa, the Bengali word for volunteer or promoter, a local woman who provides door-to-door educational services in health, hygiene, and family planning, while selling essential health commodities. These community health providers now number more than 100,000 in Bangladesh and work in 6 other countries. BRAC's interventions on maternal and neonatal health helped Bangladesh halve its maternal mortality rate in the last 20 years. This puts the country on track to achieve the 5th of the UN's Millennium Development Goals. Other health interventions include nutrition, family planning, eye care, as well as taking TB and malaria detection and treatment door-to-door. BRAC is the world's largest private secular education provider with more than 1.1 million students enrolled as of 2012. Our schools offer a second chance to children left behind by formal school systems due to poverty, displacement, and discrimination, teaching children to think of themselves at the primary and pre-primary level rather than relying on outdated systems of rote memorization. The schools are run with the active support of the communities they serve, with school teachers chosen among local women who are trained and ensure quality. The success of this alternative schooling model has spread from Bangladesh to 6 other countries. Operating in Sierra Leone and in Bangladesh, our human rights and legal services program depends on the services of more than 6,000 deaf lawyers. It is likely the largest NGO-led legal empowerment program in the world. We address issues around sexual harassment, improve gender relations within families, and combat discrimination and violence against women. We provide services to migrants, giving them easy access to services that help them avoid exploitation. BRAC's Ultra Poor program was born from the recognition that certain groups living at the bottom 10 to 15% of developing societies are too poor to benefit from market-based solutions like microfinance. The program offers an intensive 2-year course of livelihood training and handholding. A greater percentage of these women now feel socially included and get access to formal and informal financial services. Recognizing its success, the Ultra Poor program is replicated by other institutions in 8 other countries. We have recently launched an integrated development program to serve the most deprived communities who are socially and geographically excluded from mainstream development, with a coordinated version of BRAC Health, Education, Microfinance, and Social Development Program. Operating in 8 countries, our agricultural programs work with governments to ensure food security. We build systems of production, distribution, and marketing of quality seeds at fair prices that bridges the last mile to rural farmers. Our disaster management programs work with communities to improve their response to natural disasters, with weather forecasting systems, disaster-resilient housing, and mobile salination plants. We've reached more than 38 million people in Bangladesh through our water, sanitation, and hygiene program, which works to break the cycle of contamination caused by unsafe drinking water, unhygienic latrines, and poor hygiene practices. We renovate and provide communities with new technologies to ensure access to safe water supply and sanitation facilities, while our advocacy campaign, social marketing, and formative research activities promote good hygiene practices across communities. About half the surpluses generated by our 18 social enterprises help fund the expenditure of our development programs in Bangladesh, while the rest is reinvested in the enterprises themselves. Dividends from BRAC investments support the financial health of the organization and reduce our dependency on donors. BRAC is often its own fiercest critic. Our research division assures the quality of our work, provides evidence, and inspires innovation across the organization.
Giving us board with their partners. Our job as development organization is to create an ending condition for poor people who think themselves to be actor in history and changing their own lives. And I think it is our duty to try and help in other systems, other cultures, other people, so that they can learn from that experience and do the right thing for the development of their own country.
One man's vision and the efforts of many has turned BRAC into the largest development organization in the world. Our interventions create an ecosystem in which the poor have the chance to seize control of their own lives. Our work now touches the lives of an estimated 126 million people. We remain true to our vision of a world free from all forms of exploitation and discrimination, where everyone has the opportunity to realize their potential. Bangladesh has been a hotbed of innovation.
It's a continuous loop. Okay.
A development organization.
So keep your questions in mind, and we'll hear from Jeff, and then we'll open the floor.
Sure. Well, I'll just sit here, I think. So the challenge for me is, as the last speaker in the program, is that almost everything's already been said. And of course, the saying goes, but it hasn't been said by everyone yet. So I'll try not to just repeat everything you've heard. It's been a very interesting day, and I think the presentation on BRAC just now is an important starting point for what I'm going to try to do, which is I want to try and extract a few lessons from what we've heard today and provide a broader context for thinking about the role of partnerships in really helping to deal with the challenges that the world faces as a community in global health right now. And also, just to preface what I'm going to say, most of our discussion today has been about public-private partnerships in the sense of bringing the private sector into the work that's going on in public health. Of course, the BRAC example shows us just how powerful it can be to have a community-based model of development where NGOs work closely with government and really develop remarkable tools and outcomes for populations in, I think it was 12 countries, you said, not just in Bangladesh. But I'm not going to focus much on that kind of public-private partnership, that is with NGOs and the public sector. But I'll probably spend most of the time talking about for-profit private organizations in partnership with the public sector. But let me just start by observing that this is a very timely moment for this discussion. As I'm sure most of you have been following what's been happening in the last few months and years about global health. The G7 met just a couple of weeks ago, and for the first time in years, health systems and health issues were a large part of their dialogue. And the communique, because of the Ebola crisis that had developed over the last 2 years, the communique really made a major point about the importance of resilient health systems and the fact that we need to look beyond Ebola to think about what will we do to ensure the next crisis isn't as debilitating. And in the context of the Global Health Security Agenda, they made a major commitment to help 60 countries implement the international health regulations, which should get a long way toward beginning to create more resilient health systems around the world. They also talked about antimicrobial resistance, about neglected tropical diseases. And so these are important commitments by some of the largest economies in the world and some of the major donors in the world to really help other countries address these health issues. So that's a commitment to partnership at the highest level. In just a couple of months, as several of you have already noted, we're going to be debating, as the world debates, the Sustainable Development Goals, which will be a focus of the UN General Assembly in September. And one of those goals, of the 17, is universal health coverage. So to try to use the new resilient health systems that are going to be developed to provide coverage for every health condition for everybody without risk of financial catastrophe. Now, I think the best way to describe that is that it's an ambitious and aspirational goal because health systems around the world are far from having the capacity to provide universal health coverage. But in that context, it's going to be important to take advantage of all of the resources that are available and all of the skills that are available in the global health community to try to help countries reach that goal and to improve health outcomes for citizens around the world. Now, Rifat Atun this morning pointed to the, as he called it, the post-Bretton Woods picture of how the world is changing. And that's also relevant to trying to understand the role of partnerships. Because, in this new world where it's not just the WHO and the World Bank and intergovernmental relations that are going to govern how global health issues are dealt with, what we have is an emerging new paradigm of global health governance. And it's one in which everybody's going to have to do business in a new way, not just the private sector, but governments and NGOs as well. And we're going to need new mechanisms, and those new mechanisms are going to have to reflect new principles of governance, transparency, participation and engagement, clear accountability for success and failure, coordination and coherence, and a new eye on priority setting that will help us achieve the ambitious goals that are there, and also with an eye, as Rifat mentioned, to equity as well as efficiency. And also, I think Clarion mentioned the importance of rule of law in all of this. So the reason I mention that is that this is all in the framework of broader issues around politics and public policy, and global health has to be seen in that context. At the same time, we're going to need to have new ventures adapted to this new environment, which means it's no longer going to just be an all-of-government approach, but we're going to need all-of-society approaches to address these issues. And we really have to develop, from that vision, we have to develop practical ways to make sure that all participating stakeholders have a chance to contribute to these new solutions, and that the way in which priorities are defined and made clear and implemented has to also include participation of those stakeholders and how those priorities are set, and who's going to contribute, and how we're going to make progress towards shared goals. So that's the second point, that it's an important time for the global community. We all have to start thinking about new ways of doing business, and those new ways of doing business have to be as inclusive as possible. So I want to just focus for the next few minutes, and then we'll open the floor to discussion on what are some of the practical implications, of how to implement these insights. It's true. I mean, it's just a truism. I don't have to dwell on it. That all of these decisions, and I think it was Simon who made this point, have to be made in the context of political choices. And we've also heard about the importance of cultural aspects of developing partnerships. And by cultural, what I mean is, I'll just give you two examples from my own experience. I think Joe alluded to the fact that I've worked in the private sector at a large multinational corporation. I've led a large international NGO, and now I work and have worked with various governments in Africa and Europe and others on a variety of issues. I've led some major global partnerships. I've led small, national partnerships in health. And my conclusion from that, and this is something many of you have already observed, but I think it's hard to overestimate just how little people from different sectors understand about how other sectors operate when you sit down to start talking about a partnership. Gina mentioned this point before, that even if you use the same words, you may not mean the same thing. And Brenda, worked with me on a partnership in Botswana on HIV and AIDS that involved the Gates Foundation, Merck & Co., and the government of Botswana. And it took years, literally years, for us to develop that kind of common understanding of what we were trying to accomplish. And it wasn't just that the government didn't understand the private sector, and I think it's fair to say that the Gates Foundation had its own point of view, and it wasn't always clear that, that the other two partners in this understood that as well. So that's one example. The other example is, and this gets to the point about trust that many of you have mentioned, and I think that it was put quite well in that last session when you said, I guess it was Christophe Longuet who actually made this point, that trust has to be earned. It isn't just something that you can assume. But another anecdote I just want to mention is about 15 years ago, when I was at MSD, we began to develop some joint work with WHO Euro in Copenhagen. So I went to Copenhagen to meet a number of the key people at WHO Euro and to talk about the work that we might be able to do. In this case, it had to do with health targets and with health education. But toward the end of a long day at Euro, just meeting people for the first time, and obviously there was someone within the organization who thought it was a good idea to try to work with a large company like MSD. But at the end of the day, I went to meet the number 2 person at WHO Euro, who at the time was a Russian, who was responsible for management and operations. And when we sat down and we'd been served a cup of coffee, the first thing he said to me was, "Who are you and what do you want from us?" So, which was sort of welcoming and made me feel warm and fuzzy. But that just shows that let's just call it skepticism was it was a natural reaction, and ultimately we discovered. I explained what we wanted, and it was actually what they wanted as well. And that's also an important point about partnerships, that you have to find common ground, and that's the only way to succeed. So those, I just want to make that point, and all it does is reinforce a point many of you have made, that even if you're sitting at the same table, ostensibly to negotiate a partnership about something that you both care about, the people around the table inhabit different cultural worlds. And so that's just something to keep in mind all the time, and it's something you have to work on constantly. So then let me just turn to some of the more practical questions. Now, Richard asked one of the questions that I wanted to pose, because I think it's important in the interest of transparency when you're thinking about developing new partnerships, is really to be honest about what's in it for the private sector, what's in it for government, what's in it for the NGOs. And just speaking broadly, what's in it for the private sector is that, actually Gary Cohen made this point well this morning, that the discipline and the skills involved in developing multi-sectoral partnerships are actually exactly the skills that companies need to move into new markets and to do business in a different way in places where they haven't been active, moving into Africa, into Southeast Asia, and in markets in Latin America. So that's one thing that's in it for the private sector. It's an important learning experience. Another thing is that companies are as affected by ill health and the productivity impact of ill health as governments and anyone else living in a society. And so there are, for that reason alone, because businesses have such a stake in the societies in which they operate, because they have to depend on workforces that are able to come to work and produce and not be affected by ill health, the private sector just does have a stake in health as a public good. Then if you turn it around and just say, well, what's in it for the public sector to work with the private sector, I think there's value in that engagement in a number of ways. I mean, first of all, as I started off by saying, I mentioned the G7 health agenda and the SDGs, but let's not forget, and we've talked about a number of them, and the BRAC example shows us that there's still unmet business in the MDGs. Right? There's still too many women who die in childbirth. There's still too many kids who die before the age of 5. We still have an increasing number of people with HIV, TB, and malaria. And then when you move from infectious disease to non-communicable disease, 10 times as many people die each year from heart disease as die from HIV. The number of people with diabetes is something like 350 million and growing. We haven't even begun to deal with mental health issues, with oncology around the world. So there's a huge unfinished agenda in global health. And from that point of view, the only way to deal with the complexities and the resource requirements and all the other things that need to be done is for everybody who has skills and resources to contribute to those potential solutions to be at the table and trying to find ways to work together. So that's one reason why it's important for the private sector to be engaged from a public sector point of view. And also, it's doing that will also enhance economic growth and development because of the links between health and wealth that you all know well. So, these are all good reasons why we should be working together, and that just underscores the importance of the challenge that this forum has put before itself to understand how to make sure that more of these partnerships are catalyzed and organized in effective ways. And then let me just say a couple of words about another dimension of this that I don't think that we've really focused on as much in today's discussion, although I think I'm sure you're thinking about it as well. And that is that the private sector is not monolithic either, any more than government or NGOs are. But most of our discussion today has been focused on large multinationals working at global level on partnerships. Occasionally we've gotten into large multinationals working at the national level, and we've spoken a little bit from the other point of view of NGOs, seeking out private sector partners and governments working with them. But it's largely been, except for Jeanette Vega's talk this morning, we haven't really looked at this from the point of view of what's happening at the country level. What do health ministers and finance ministers and hospital directors and healthcare practitioners in Malawi think about the challenges they face and how they're going to get help to do this beyond the donor community? And so in thinking about that, let's not forget that already there's a tremendous amount of investment in healthcare in the developing world. And also, and I think this was mentioned by Gary this morning, in many countries, certainly in most of sub-Saharan Africa, more than half of healthcare is delivered through the private sector. It's even higher in India, and it's equally high in other places in Southeast Asia. So it's not a question of whether the private sector can help. It's already happening. The question is how to manage the complexity. And that complexity also has to do with the entire spectrum of prevention care, treatment, and treatment. So you've got at the country level, you have private clinics, private pharmacies, drug kiosks, social franchises, even informal practitioners, and it's hard to know how to organize them. And then, of course, you've got the private sector involved at all stages of the value chain as well. And we've heard examples about supply chain management, but you've got distribution and retail, you've got manufacturing and supply, you have all the other health technologies that are around. Jeanette Vega's presentation about the work in Chile reminds us about the role of private health insurance. You've got medical education, and then you've got partnerships on for innovation. Steve Davis gave us some good examples of PATH's work, but you've got development partners, and then even such ambitious partnerships as the one between Netcare and the government of Lesotho to completely reconfigure the main hospital in Lesotho. So I think that I just want to allude to these points and just keep in mind that we have to keep this complexity in mind as we think about ways to encourage more public-private partnerships, and also to encourage ones that work on in ways that will actually help us get to scale. Because this has come up a couple of times through the discussion today. But for instance, BRAC's experience shows what's required to take these kinds of partnerships to scale. And that is NGO and government working together. And of course, BRAC has also had private sector partners. But it's taken a number of years. But now it's very impressive to see just how many people are being helped through the work that BRAC has done. I think it's fair to say that when you consider, with some exceptions, but when you consider corporations having worked together with governments and NGOs and the kind of partnerships we've been talking about today, there aren't many examples where those have actually gone to scale, where you're talking not about a few hundred or thousand people being affected, but millions or tens of millions of people being affected. And that, after all, is the challenge that the global community faces. So we need to find ways, if partnerships are really going to be as central as we think they should be, we have to find ways to get them to scale. So I want to just end with a couple of points. We heard earlier a good example of, and actually we've heard through the day, a number of different principles of organizing public-private partnerships. I want to just emphasize a few that I think are critically important. One of those is that none of this is possible, certainly at the country level, without high-level political commitment and engagement. That was another thing that we saw in the partnership between MSD, the government of Botswana, and the Gates Foundation, when, and I mean, there's no reason not to just be blunt about it, when Festus Mogai was president of Botswana, he was a champion for this program, which has had a tremendous impact on how Botswana's been able to deal with HIV. After Mogai stepped down and President Khama came in, he was not, let's just say he had other priorities. And that had an impact on how effective that partnership was able to be at just the time that they were trying to grapple with an even more difficult question, which was the prevention agenda for HIV in Botswana. But political engagement is absolutely critical. The other thing that, and this is a simple point, but it actually, I was surprised it hadn't come up much today, that if you're going to create a partnership, the partners have to agree on what the project is going to accomplish. It's very simple. Again, this came up in different ways about talking about having a common vocabulary and other things, but you don't actually have to agree on everything. You just have to agree that you're going to work together to fix this problem. And once you've done that and defined roles and responsibilities, you generally can make some progress, particularly if you focus on continual communication among all of the different partners, because that's another thing that I think many of us could tell stories about how it's easy to drift off target if you're not constantly communicating with the other partners in a project. The other 2 points I wanted to just make are that in the long run, programs have to be country-led to succeed. And also I think that, and again, BRAC's a great example, that to get to scale, to be sustainable, ultimately you have to have programs that are country-led. The U.S. government has finally come to that conclusion over the last couple of years after about 50 years of development assistance, at least since USAID was founded, and now they're very focused on country leadership and domestic resource mobilization. But there are plenty of examples I could go on, but I won't, but that's an absolutely critical success factor. And then another one that's allied to that is building local capacity, and again, that's come up in different examples. But that also is both critical for success and critical for long-term sustainability because the partners are not always going to be there. And ultimately the country has to find a way to build the capacity to manage these programs on their own. And then finally, I think the other thing to keep in mind is that persistence pays off. That's the other thing. It's not always easy. Things don't always work well when you start, but if you persist, as the example of BRAC shows us, you can accomplish amazing things. So I hope those are a few helpful remarks.
Thanks. I'm going to start off with a question to each of these folks and then have you while you're thinking up your questions. Mushtaq, I want to ask you something. There's a very interesting, I don't want to go into this particularly, but I want to flag the fact that you call yourself a development agency, not a health agency, and I think that's really a very important part because many of the areas you listed that you're active in around poverty, education, food, et cetera, is, sometimes if we get into this health as health care, we lose contact with the kinds of variables that you're talking about. But you didn't really explicitly mention your BRAC's partnerships with the private sector, with the business sector. You talked about, I think, BRAC adopting market models and business models as social entrepreneurs and entrepreneurs in terms of some of your recent, I was recently in Dhaka and saw the signs of BRAC chicken and went to the stores where you're selling garments and other things. So do you in fact have business partners? And if so, could you talk about that a little bit as opposed to adopting a business model yourself?
Yes. The work with the the for-profit sector happens in many different ways. One of the ways is that, for example, Unilever, they give us money to implement a ultra poverty program to remove ultra poverty. So that's one kind of work that we have with the private sector. Then we also have work with the local private sector. We have this MNCH program, the maternal, newborn, and child health, and we don't run any hospital ourselves. So we have to depend either on the government hospitals or on the private hospitals. And government hospitals are not always responsive. I mean, there are questions of quality and so on and so forth. So we have also come in contact and MOU with the private hospitals. When a woman has problem with respect to the emergency, we send her to those private hospitals, and they provide the services sometimes at a subsidized price. So that's another kind of relationship that we have. Then also we have been able to really train local entrepreneurs. Say in terms of sanitation, we have trained thousands of local entrepreneurs who are producing latrines in the villages. We give them a loan as a kind of initial fund, and then they manufacture latrines and then sort of sell them to the community. So that's another kind of work that we have with the private sector. And finally, we also work with the private schools, we have seen that in the secondary schools, the students fail in specific subjects, so science, English, and mathematics. And we have been working with the private schools in order to train their teachers on these specific subjects. So there are many ways that we work with the private sector in health and also in other sectors.
Mm-hmm. But would you say, I guess I don't want to prolong this too long, but we've been talking about these models of philanthropy, corporate social responsibility, mm-hmm. and shared value. Do you have any shared value partnerships in the sense that you're both, there's a win-win on the financial side? Is that explicit as a part of the relationship that you have?
Yeah, I mean the CSR thing. I mean the Unilever work that the partnership that we have, mm-hmm. which is supporting specific programs of BRAC. But those partnership only happens when we have kind of same or similar kind of values. Mm-hmm. So that's the minimum thing that has to be there.
Great. And just a question for you, Jeff, and we haven't really talked about this either, so maybe open it up for the group. One of the questions of private partnerships in country, you raised the in-country issue and the degree to which companies could and or are, in your experience, helping to develop local business as instruments for engagement of the private sector, the indigenous private sector with public or NGO sector. I just sort of raised it. I think one of the issues in some of the early conflicts about formula versus breastfeeding and other things was that the decisions made at the global level were quite reasonable in terms of what needed to happen. By the time it got implemented at local level, either through local companies, other local companies, or the local chains of the exact local parts of the larger multinational, it wasn't quite going as planned. I just wonder if you could talk about that.
Sure. Well, I think one of the most interesting, Rifat this morning talked about the need for more evidence, and I think one of the most interesting questions right now that could use more investigation is the diversity of the local private sector in health in different regions around the world. I'll give you just two quick examples, because I think, one example to answer your question directly, Joe, is We've been doing some work with AstraZeneca, another pharmaceutical company in Kenya, on hypertension. Just briefly, there are 8 million people in Kenya who have hypertension, and hardly any of them know it. And the way that the health system had been organized to deal with hypertension was that a few cardiologists, each of whom treats just a few hundred patients, were trying to deal with all 8 million of these individuals. And so AstraZeneca has brought together a partnership that includes a number of implementing partners, organizations like PSI, Population Services International, JPIGO, AMREF, and a few others, who have been working with PEPFAR funding over the past several years to develop primary care, the primary care system to deal mainly with maternal and child health and HIV and AIDS. But it's relatively easy to integrate screening and diagnosis of blood pressure and then treatment of hypertension into the primary care clinics that are already there. And so that, and then also working with CHAC, the faith-based association, the Association of Faith-Based Health Facilities, is another partner in this. They're actually beginning to get to about 21 of the 47 counties in Kenya, and so this is going to have a major impact over the next few years on the diagnosis and treatment of hypertension. But this is all, for instance, PSI has a network, a social franchise of several hundred pharmacies who are part of this network, and so that's one way in which they're working with the local private sector to actually manage this major change. And then they're also training community health workers, working with some of the other NGOs who are part of this. And so it's, it really, I think it's a good example of bringing together a wide range of resources in Kenya under the auspices of the national strategy for NCDs. So this is something that the government had essentially an unfunded mandate to deal with hypertension and cardiovascular disease, and this is a way of mobilizing the resources and really trying to make a difference in that. Another example I could give you is the London School of the London School of Hygiene and Tropical Medicine. A team led by Una Campbell recently has published a couple of papers on an analysis they've been doing of where do women go to deliver babies. And they've been using the demographic and health surveys from 57 countries and reanalyzing all the data. And what they found is there are about 125 different private providers who women have been using across those 57 countries. And in fact, most women use some private provider rather than depending on the public sector. I don't remember all the statistics, and I won't bore you with them, but it just showed that this was presented last year during UNGA week at some highlights of it were presented. And Tim Evans, among others, Tim Evans from the World Bank said that this was just surprising to him because nobody had any idea that there was really that diverse a network of local private providers providing help for women in delivering babies. So I think, just to come back to where I started, I think that we're likely to find an equally diverse and robust community of private providers in the local private sector. And if we knew more about who was there and what they were doing, it would be a way of really creating partnerships that would really help reach more people.
Cards up for questions. Patrick, you ready?
Yes, I had questions about sustainability and exit strategies. Now, some public-private partnerships, I guess it's pretty obvious when they will end. But I'm wondering if you could comment a little bit about how you recommend handling more long-term public-private partnerships to, I'm assuming that in most of them there is some vision of an end of the partnership. How do you incorporate into the partnership approaches that would ensure that that ultimately it's sustainable, and that when the time comes to exit, there is a smooth transition to a better future?
Well, I mean, in terms of the exit strategy, Just to give you an example, we run a eye care program through which we do the cataract operations. And in that, we work with our partners who are in the private sector who do the cataract surgeries. And our purpose is to get each of the district rid of cataracts. So once that objective is done, obviously the private sector that we have been working with, they know that there is no more work there. So that ends the partnership in that particular district. That's how the exit strategy has been developed. But with some, it continues for a long time. For example, the government program that I was showing on the TB, this has been going on for many years. And unless something happens, this will probably continue. But that's dependent on the availability of funds as well. So if the Global Fund stops funding TB program in Bangladesh, then obviously those kind of partnerships won't be there. So it depends also on the funding situation because the NGOs not always have their own source of funding. They have to depend on funders.
I was wondering in the context also of what Jeff said about the AstraZeneca partnership for hypertension detection in Kenya. I guess I'm assuming at some point in time this would not be something that that AstraZeneca would want to just continue supporting and subsidizing the Kenyan healthcare system to detect hypertension. Is there any effort woven into the project to incrementally turn over to an appropriate local responsible body the management and the funding of that program? Do you provide not only services, but do you provide some way of creating a business model that's sustainable?
Yeah, no, that's a very astute question. So let me come back to your first question about sustainability and exit strategy, and how do you incorporate those into partnership plans. I think one of my principles is that that's part of the design of the partnership. So when you first sit down to talk about what you want to accomplish and begin to set out the parameters for who's going to do what and what you're going to try to what health impact you're going to try for, you have to design a sustainability plan, because it's the same for any situation in which a donor comes and provides resources to an organization or a country, in this case, that didn't have the money before. You've got to think of some way to incorporate that into the long-term plan. So that's part of why I emphasize country ownership and building local capacity, because those are two of the elements that are important parts of sustainability. But just to stay with the example in AstraZeneca, and just to be clear, I don't speak on behalf of AstraZeneca, so what I'm about to say is my opinion. But part of this program, there have been three components to it. One is education and awareness, because most people, as I said, don't know they have hypertension. The second is to work with the healthcare community to develop protocols, and that includes working with the government to develop some simple protocols to treat people efficiently. And then the third element of this program was that AstraZeneca redesigned its supply chain so that they could provide their hypertension medicines for about 10% of the price that they had been charging. But now that they've done that, they can continue to supply those products at 10% of the price indefinitely, and that's essentially a price equivalent to what the average price was of other antihypertensives in the market. So, and again, this is my opinion, so don't, it's not what AstraZeneca has said, or it may not be what they're planning. But from my point of view, that actually is a model towards sustainability. So they don't have to think of it as an exit strategy. They've now reshaped the market so that people will continue to use those products. They can continue to supply them. They have a very low margin, but they still have a margin. So it's actually a sustainable business. And the other components, by the way, of the program are, because this has been designed with other implementing partners, they have an interest in just continuing to do this work to provide better service to to the population that they serve. Because, for instance, one of the facilities that's involved in this program is AMREF's clinic in the Kibera slums, and they weren't doing anything about hypertension until this program came along. But now it's relatively simple to just take blood pressure whenever patients come to the clinic, and then they now have a way of providing treatment and keeping people on treatment. So it isn't a heavy lift to actually integrate that into the primary care that they were already doing. So I think that, that's just I don't want to bore people with more detail on this, but it's just to give you a sense that we've been thinking about how to build sustainability into the program. And eventually AstraZeneca will stop subsidizing the work that was done to train the community health workers and to help the implementing organizations do the extra work to integrate this into the care offerings they had. But it should be sustainable because there's a huge unmet need for that, for those services. And these organizations now are in a position to provide quality service to the population. So I think it will continue. And from AstraZeneca's point of view, again, my opinion is they'll find that this should be a sustainable model so that they can continue to supply their medicines. And for that matter, there are plenty of other antihypertensives in the marketplace, so it's not necessary that it be sustainable for AstraZeneca because there are plenty of other companies providing these medicines. And just one final point, and because it's something that I was thinking of earlier, one of the things that, from Simon's comments about Gavi and the Global Fund, I actually think that as important as partnerships can be and have been and will continue to be over the next several years as countries work to achieve universal health coverage, what I think is even more powerful is, and the reason I emphasize this point that everybody has to think about doing business in a new way, what would be even more powerful are business models that are sustainable. So if you look at, this is something that's always puzzled me. If you look at microprocessors, for instance, and the way, we're all carrying smartphones that have more power in them today than the largest computers in the world 30 years ago. And they cost a fraction of what they cost even 5 years ago. So why is it that technology in that field has become cheaper and cheaper and better at the same time? But in healthcare, we simply haven't been able to figure this out. But if somebody can crack that code, if we continue to experiment with new business models, it should be possible to provide better quality at lower cost for more people. And actually, that's the only way that we're going to solve the problem of how to achieve universal health coverage. So that's just looking ahead to what I think is going to be the next big question that we grapple with.
And just to finish up, I was talking with Jeanette Vega before she left, and one of the issues we struggle with in the United States, here in New York, we're working with hospitals on something called community benefit, where they have an obligation to the IRS to invest in communities, but they say, well, we don't want to put the money out there because we don't have any control over what happens, if we invest in X program or Y program. And I just said, and they also say that that the money that's being used for that is not real money. And it's sort of, they have to do a reporting thing, but actually from a savings point of view, it's not real money. So you can't say, let's take it out of the acute care sector and put it into the primary care sector or into population-based prevention. And her reaction, I said, how do you deal with that issue? And she said, well, it's easy if you have a public health system because I pay the bills. So apropos of Jeff's point, if I begin to expect reduction in the acute care cost and shifting of that cost into other sectors, I will push that and in some ways force it to happen. Whereas if you have a mixed session, this is her words, if you have a mixed system or a wildly decentralized system with private sector, it isn't real money in the sense that I can't take those savings and move them somewhere. So it's a really interesting, I think, question. We talked about it earlier today, the sort of finance incentives for shifting the conformation, if you will, of the healthcare sector at least. But she potentially could engineer that or push that, having a health system. If it's public-private mix like that, it isn't very easy to reallocate. Anyway, interesting question. So thank you both very much. Let me ask the audience to thank our panelists. And, And over to you on time.
Thanks, Joe. It's great. And if you guys just want to stay there, I'll wrap this up really quickly and we can adjourn and go to the reception. So I'm not going to do a big summary of the day. Thank you very much, everybody, for your participation, attention and consideration through what I think has been a terrific day. We looked at ecosystems, at landscape, at incentives, at innovations, and a couple of sessions on lessons, and I think it's been a great mix. Jeff, you did a really good job of synthesizing some of that in that session, which was really helpful for us. Please this evening reflect, digest, think about distilling and synthesizing some of the things we've heard over the course of the day and bring them back tomorrow. Tomorrow we're going to sort of cap this off by first looking at some approaches to partnership and innovations at Narayana Health, and Dr. Shetty will be joining us. We're going to start at 8:45. It's a video. I highly commend Devi Shetty's presentation. It'll be fantastic. So please let's try and be here on time so the video can kick off, because I guess it's pretty late in the evening. There's a lot of people working out of time zones, Mushtaq, so we're going to be working with Devi from India. We're then going to move on and look at measuring performance and metrics, which is crucially important. We've alluded to it a couple of times today. And then reflect and think about sustaining and increasing investments in health system strengthening and public-private partnerships. And then we'll do a final session to wrap up and further synthesize and think about some next steps. So with that, I think we have a reception that's ready. Thank you very much.
Thank you.